in our day-to-day practice, hernia is one disease which we come across very, very soon, and we must know everything about as far as the hernia is concerned. Now, what is this? What this word means? Actually, hernia is a Latin word. It means rupture. In Greek, this means an offshoot or bulge. So, rupture of the wall, which is supposed to contain a viscous or something, that something may be muscle, fat, or even heart if protrudes through the pericardium, or even the testis if it comes out of the diatus muscle beneath the skin. All these are hernia. So hernia actually means rupture. That means the wall which is supposed to contain that viscous or the thing has broken. The defense has been broken and it has come out. Now, what are the types of hernia? The hernia can be classified in various ways. As far as first we should know the cause, that what causes. There is not a single cause. It has got multifactorial cause. One is that it is congenital or preformed sac. Preformed sac, Mr. Russell pronounced this theory, that in all hernia there is a preformed sac from the birth, and due to some coexisting factor or factors which develop later on in the life, hernia recurs. So congenital factors. Then the weakness of the collagen tissue. Mr. Conan, he came out with the view that those persons who suffer from the hernia, in them collagen tissue synthesis is less stronger than the normal one. And they grew it in the test tube and they found, or in the lab, they found that the synthesis of this tissue is less strong and less in strength in comparison to a normal person. The third, that the repeated rise of pressure. Now the wall is there to protect your organs. Now if the pressure rises on and on, either in acute form or in insidious or chronic form, so that the defenses of your wall is broken, then hernia will take place. Acute, you are suddenly lifting something and you feel a pain and you find that there is a bulge. That is acute hernia. Chronic, confinement, cough, constipation, or increased straining during the maturation, especially in the males if there is an increase in the size of the prostate. So all these can cause propagation of the hernia. So repeated rise of the pressure. These are the three theories which has been pronounced as far as the cause of the hernia is concerned. Now what are the types of hernia? Like any disease, you can say the types, that it can be congenital or acquired. Any disease can be congenital or acquired. Congenital means one which is present right from the time of birth. Acquired, which is acquired later on in the life. Now this can be acute, as I told you, or chronic. This is one way of classification. Another is that it can be concealed or revealed. Revealed means one which can be seen from the outside of your body. You can see that there is a big bulge in the abdomen. You can see that there is a big bulge in the groin. then it is revealed, it is visible, and concealed the hernia is there, but you are not seeing it. So what are the types? This is one way of classification. The third way of classification is according to the content. According to the content, the hernia may be a fatty hernia, as it happens in the epigastric hernia, because it contains only fat, or there may be omentocele, means only omentum is there, or enterocele, where gut is there. Now this gut may be complete gut or may be just a part of it. It is like this. A part of it is in the hernia. Then it is called Richter's hernia, or it is also called Litter's hernia. He was a French surgeon. He first showed it that in the sac of the hernia, it's not only gut, but it has got a inflamed Meckel's diverticulum as well, Meckel's diverticulum. Then it is called Litter's hernia. But nowadays, even inflamed appendix or a twisted ovary is there, then also we count it as a Litter's hernia. Then it can be Rokitansky hernia. Now, Rokitansky hernia is nothing but this is gut, and the mucosa is torn here, the serosa is torn here, and mucosa bulges. This is also, we can say that it is a false diverticulum, not true diverticulum, but it has been named as a Rokitansky hernia as well, after the person who first described it. So according to the content, then hernia can be classified according to clinically. Clinically, a hernia can be complete when it has got all the components and it reaches up to the end, or incomplete, or bubnocele, something like that. Now, in the complete hernia can be reducible, irreducible, obstructed, incarcinated, strangulated, gangrenous, with or without peritonitis. Now, what are these things? This is a clinical say that you say that a hernia is a complete hernia. Means, suppose in groin, if it reaches up to the scrotum, or suppose in the abdomen, it is protruding out completely, that is a complete hernia. Or incomplete, when everything is not that big. Reducible, every hernia to begin with, it goes in. Patient कहेगा कि when I am standing, it comes out. सोते हैं तो अंदर चला जाता है, या पेन करता है तो दबाने पर अंदर चला जाता है with sound of gurgling. Then that is called reducible hernia. Soon, these are different stages actually. The hernia which is reducible from the beginning may become irreducible later on, because it gets adhered. Then a irreducible hernia may become obstructed hernia. Obstructed hernia, we say, when the hernia, the gut has been obstructed, but the venous drainage has been affected, but arterial supply is intact. Then it is called obstructed. Incarcerated hernia is that where the obstruction is from the inside, ficcolith or something like interception then we call, if it is obstructed from the inside, then it is called incarcerated. Now soon obstructed hernia will become strangulated. Here in the obstruction I told you that the venous drainage is stopped, and in strangulated hernia arterial supply is also cut. Venous drainage is first cut because it flow at a low pressure, and then very soon due to edema arterial supply which is taking place at the 120 millimeter of mercury, that too gets stopped. Now once it is strangulated, soon it will become gangrenous, and later on it may be associated with peritonitis or may not be associated with peritonitis. So this is clinical classification. Then according to site. Now in content, one thing I forgot to tell you, Medell's hernia. That is interesting hernia, that you see in sac that the content is like this. So neck is over here, and you think that there is no gangrene, but the gangrene is over here, it is inside the abdomen. So this is called Medell's hernia, and this is quite interesting. That's why when you are dealing with a hernia which is obstructed or strangulated, if it has reduced inside the abdomen, you must open the abdomen to see that it has not been reduced in masse. ऐसा नहीं कि समूचा का समूचा अंदर चला गया and still it is strangulated inside the abdomen. Then you are going to lose your patient. Yeah, you must see whole length of the strangulated gut, there is no black spot into that. Now according to site, it may be inside the abdomen, outside, in midline, esophageal hernia, and then in the pelvis. Now inside, we have got some natural foramina inside the abdomen, or some unnatural foramina may occur. For example, commonly present, always present, is foramen of Winslow. Foramen of Winslow. Sometimes very pronounced. This is in the lesser mesentery, between the liver and the stomach. In the anterior side, you have got the bile duct, hepatic artery, and the portal vein. So, and beneath is the vena cava, and in that upper side is the caudate lobe of the liver, lower side is the duodenum, from where the hepatic artery ascends like that. So you can, it has got a capacity to accommodate two fingers of yours, so gut can enter in foramen of Winslow. Then you can get foramen of Bogdelok, foramen of Waldeyer, or paraduodenal and paracecal recesses. Now what are these? The foramen of Winslow, I told you that it is present in the lesser mesentery or lesser omentum, between the liver and the duodenum. The foramen of Bogdelok, we have got hiatus hernia, which is a big natural foramina between the two crusts of the diaphragm, through which aorta and esophagus and inferior vena cava, they are having separate holes, but esophagus comes. Now there can be sliding hernia, that is called hiatus hernia over there. But foramen of Bogdelok is that the diaphragm is like this. This is the esophagus. Now one portion of it is missing over here. usually on the left side, there is a big gap. So through that, there can be herniation. That is foramen of Bogdelot. Foramen of Waldeyer is of quite interest. I have got nearly 3 cases in my life, but then superior mesenteric artery, it comes like this and supplies all the vessels. In the mesentery, the vertebral column is here. So usually there is nothing in between the two. There is no gap. But sometimes a gap takes place. And when a gap takes place, the gut may enter into this. And you can get a hernia. That is called foramen of Waldeyer. Then around duodenum, you have got a small recesses, a small cavity. Then around cecum, you have got a small on the upper side of the ileum, lower side of the ileum, retrocecal. In them also herniation can take place. So inside the abdomen, you can get inside. Then outside, you can get in the midline. In the midline, you have got the epigastric hernia, which is very common. You will find there is a little bulge in the linea alba, and it contains just fat. But sometimes it may contain gut if the sac is big. Then Spigelian hernia. The rectus sheath is formed like this, and anterior abdominal wall is here, pelvis is here. So on this border, if any hernia takes place, this is called Spigelian hernia. Now apart from internal and outside, we have got in the midline epigastric hernia, which I told you. Umbilical hernia is always there. Rather at the birth, many a baby have got umbilical hernia, but in 3 to 4 years, they disappear spontaneously. You should not do anything. Previously what we used to do, we used to put equine and then we used to strap. That causes more harm. Just leave the baby. 90% chances will that it will disappear by itself. If by the age of 4 years it does not disappear, then certainly what we do, that we repair it. So over here, then in the midline, below the umbilicus, apart from umbilicus, mostly this type of hernia you get incisional hernia. In the cesarean section, many a lady doctor, always you get a case once or twice in a month, because this is relatively avascular, but it is easy to approach. In one stroke, they can go up to the uterus, but healing is poor. So this poor healing leads to hernia, that is called incisional hernia. So in midline, these are the types of the hernia. Then you can get in the pelvis. In the pelvis, we get true hernia or false hernia. True and false. False hernia is that as cystocele, rectocele, females they always have, that through the vaginal wall, the rectum protrudes, but it is not a hernia. It is not a complete thing, it is just a descent. There is difference between prolapse and hernia. The prolapse takes place through the opening, which is meant for that. Means uterus will prolapse through the vagina. The rectum will prolapse through the anal canal. And there will be continuity in the wall. जैसे ये छेद है, this is a hole. If anal canal prolapses, then if you find that there is a continuity, here your finger will stop because anus is prolapsing here. So this is prolapse. In hernia, there is no continuity. So there can be false hernia in the pelvis or true. True hernia in the midline in the pelvis. Usually after vaginal hysterectomy, we do get. But as far as in the lateral walls is concerned, the most interesting is the levator ani, which is taking origin from the tendinous fibers, which is rising from the pubic to the tip of the ischial spine. the levator eye is taking origin. Now there should not be any gap between the obturator internus and these tendinous fibers. If there is a gap, if the tendinous fiber goes like this, then what will happen? That there will be a gap. This is called hiatus of Salve. Hiatus of Salve. And then herniation can take place. The lady or gent will not, you can't see bulge, but the lady will always complain, or the gent will always complain if there is a pain, there is difficulty in, especially in defecation. Sometimes it can come out with the obstruction. Then any foramina can give herniation. We have got greater sciatic notch, we have got the lesser sciatic notch, we have got the obturator foramina. Through all hernia can take place. Then on the posterior aspect, above the iliac crest, on the posterior aspect of the abdomen, we have got this is the 12th rib, this is iliac crest, this is the rectus spinae muscle. So here there is a triangle, what is called auscultation. This is 12th rib, auscultation triangle. In our days, when the things were not that much developed, we used to hear succussion splash through that, in the cases of pyloric stenosis, because it was just behind the stomach and you could, जैसे घड़ा में पानी हिलाने पर हिलता है, हम लोग उसको सुनते थे. This is called auscultation triangle. And over here we have got a Pettis triangle in the posterior side. Through that also hernia can take place. So these are the type of hernia which you can get. Now how to diagnose it? Diagnosis in our time was difficult, especially of internal hernia. Sometimes, many a times, diagnosis used to take place only when you open up the abdomen. When you don't find any reason, we used to open up and we used to find that there is an internal hernia. But nowadays, thanks to ultrasonography, then we have got, you can give a gastrography and follow through, and that will show that where gut is herniating, or CT scan or MRI, that will tell everything. In our days, we had got only two ways to identify. One was peritonography, that will put a dye into the peritoneum and that will show that where the things are going. Or you can do a laparotomy. Now laparoscopy also can reveal so many types of hernia if patient has not come with the obstruction. Once diagnosed, how you should manage a hernia? There is no role of conservative. So operation has to be done. And in operation, you must know perfect anatomy. I will not deal with all the anatomy, but two things you must know. The one is that in the anterior abdominal wall, the most common one, the anterior superior iliac spine is here, and then pubic tubercle is over here. So between the two there is a ligament like this. This is inguinal ligament. Now it is curved. It is curved. This inguinal ligament, which is going from the anterior superior iliac spine to the pubic tubercle, it is curved. It is nothing but the folded portion of anterior abdominal wall has got three muscles: external oblique, internal oblique, and transversus abdominis. So external oblique gets folded like this. This is inguinal canal. So this is inguinal ligament which gets folded upon itself. It gets folded upon itself, and this is inguinal canal. Now it is attached over here. Now its beauty is that it is made of anterior abdominal wall throughout its length. In the lateral 1/3, the lateral 1/3, the internal transversus abdominis will come, and in the 2/3 portion anteriorly, the internal oblique muscle will come. So anterior wall of the inguinal canal is made of external oblique throughout, internal oblique and transversus abdominis also. And posteriorly there is only transversalis fossa. From here, the fibers of these are the fibers of the external oblique. These are the fibers of the transversus abdominis. They arch like this. This is called conjoint tendon. Conjoint tendon. And through this comes the, in the male, vas deferens and ilioinguinal nerve, in the female, round ligament of the uterus and the ilioinguinal nerve. Now, you can see the beauty of this structure, that on the lateral side it is thick anteriorly and medially it is thick on the posterior side, and it is giving way. Here there is a small ligament where there is vas deferens is entering. It surrounds. This is called interfoveolar ligament. Interfoveolar ligament. Now, if you can identify that if you open it, it is just only 1 finger breadth. So when you open it up, you find that the fibers are going like this. These are the 2 crusts of the external ring, and then you find intercrural fibers. So this is the place which you have got the inguinal canal. If you open it above, you will go into the abdomen. If you open it up below, you will go into the thigh. So you just must identify these 2 points and then you open up. Now it contains, as I told you, ilioinguinal nerve and cord. Now cord has got so many things you should remember, and you can remember it by that it has got 3 coverings. The 3 coverings are external spermatic fossa, cremasteric fossa, and internal spermatic fossa. So it has got 3 coverings on it, the cord. It has got 3 nerves in it. The genital branch of the genitofemoral nerve, sympathetic and the parasympathetic. It has got 3 arteries in it. Artery to the vas, artery to the cremaster, and testicular artery. It has got 3 contents: processus vaginalis, pampiniform plexus of veins, and the vas deferens. So by this way you can remember that it is made of 12 structures. Now hernia is a very common thing over here, and I will tell you how to operate in few lines, not now. So here inguinal hernia takes place. Now when this thing is getting attached over here, then from here it goes like this on the pubic bone. This is part of the inguinal ligament. It was in the abdomen. In the thigh you see, then if you find that there is a part that is called ligament of Cooper. Ligament of Cooper. And over here there is a ligament like this. This ligament is called lacunar ligament. Lacunar. So inguinal ligament is also called Paupert's ligament. This ligament, lacunar ligament, is also called Gimbernet's ligament, and the reflected portion is also called ligament of Cooper, which is here. Now this portion contains a big sheath. The anterior wall is formed by the fossa transversalis, posterior wall is formed by the fossa iliaca, and it contains artery over here, then vein over here, and this space is a dead space or empty space. This is femoral canal. Femoral canal. This contains a small node that is called gland of Colloquet. This gland of colloquates drains glands of the penis or glands of the clitoris. So cancer in the body of the penis is less dangerous than the cancer of the glands of the penis or clitoris, because it will straight go to this gland of colloquate and then from there to the deep gland. Now when you are operating this hernia, we close this thing. This ligament of Cooper is good enough to have the suture, stitch suture, or you can put a mesh inside as a plug, or pre-peritoneal approach we can go from the behind. But the problem is one, that there is a vessel, inferior epigastric artery goes like this. It has got two vena comitants. It gives an obturator branch which comes like this way, and it anastomoses with the anastomotic branch or ascending branch of the obturator artery. Now this artery is a small twig, so in obstructed hernia we can cut it. But in 20% of the cases, this anastomosis replaces the obturator artery itself. Then it becomes too big, and if you cut it, the person can die. The bleeding can be tremendous. So here, through this, femoral hernia takes place. Here, inguinal hernia can take place, and then other hernia, they can take place on their proper sites. Now, how to deal with hernia? As I told you, that there is a rupture. So suppose your shawl gets ruptured. What you can do? Either you can throw away that shawl, or you can apply a patch on that, or you can do a darning, rafu kar de. The same principle apply. You can't throw your body. So either we apply a mesh, that is what we call chippy, or you can do a darning. So suppose there is a defect over here. Now there is no scope of conservative management. पहले हम लोग कहते थे कि आप belt बांध लीजिए. That is more harmful. It is better not to do, because that belt will always press on the. It will not press on the correct side, but it will press at the wrong side. It will cause fibrosis of the muscle, so the muscle becomes further weak, and fibrous tissue is unyieldable. It will not yield, so chances of strangulation becomes more, and repair is always weak. So don't do anything. Now this can be repaired either by means of darning or by application of the mesh. It can be done by open method, or it can be done by closed method, or minimal invasive method. Now, as far as mesh or no mesh, if you have got the correct knowledge of anatomy, if you don't tight it very tightly, because tightening will cause strangulation, will cause death of the muscle. You should just approximate it without any tension, and if you have done it in a correct way, if no infection takes place, then darning can do all the good without having any problem. But if there is defect is big enough, more than 5 centimeters, especially in the incisional hernia, if the defect is this much, or think of a tumor. We get a dissemoid tumor at times in the anterior abdominal wall, and we have to remove whole of the anterior abdominal wall. Then from where the hell you are going to get all the things? Then we have to apply a mesh. Now mesh, application of mesh is easy, but I use mesh only when the person has got a recurrent hernia. In virgin field, the best thing is that component separation. एक component को देख लीजिए, repair it properly without any tension. Don't leave any hematoma. Have tissue respect, and you will find that there is no problem. If the patient is obese, if there is a repeated raised intra-abdominal pressure because of the suppose the patient is having confinement, gravid uterus is there which is enlarging, constipation is there, cough is there, or prostate, due to prostate all the time the patient is straining, or due to the bowel obstruction because of the stricture which may be tuberculosis or malignancy, the patient is straining, then the chances of recurrence very much becomes much. But open method and through the laparoscope. In virgin field, they both are virtually same in good hands. The learning curve is little high in the laparoscopic method. The chances of recurrence, in my opinion, is little more in the closed method, but or laparoscopic method. But if you do it by pre-peritoneal approach, which we do when recurrence is there, then the chances are less in the first case or in a field which is virgin one. But if recurrence has taken place or if the patient has been operated before, then the best thing is to operate in an open way. Now, which suture? Why I don't like mesh? Because if patient gets infected, then the life becomes hell. Though we have got various types of mesh nowadays, we have got absorbable mesh as well. We have got which can be mesh which can be put on the direct on the intestine as well. But still a foreign body is a foreign body. Now, when darning is being done, what is the best thing? When we were students 50 or 60 years back, then we used to repair it by thread, cotton thread. Then came catgut, and we thought that we have got everything, number 1 or number 2 catgut. Then came silk. The problem with the silk is that it spits itself out. Spits का मतलब कि ये sinus बना के थूक देता है, निकल जाता है बाहर. So sinus formation is very common if you use mer silk. If you use braided nylon, problem is again the same. Best thing is Proline, but the problem is that it has a tendency to unwind itself. What we say in surgical term, the number of knots which you will give, the knot will last for that long. Means if you give 7 knots, then it will last for 7 days. Otherwise, it will open it up. So what I do that after tying with Proline or monofilament nylon, I tie that knot with a silk, mer silk, just 1 stitch. So the chances of sinus becomes very much less, and that is the ideal thing. Mesh should be applied only where you have got defect more than 5 centimeter, according to me. As far as laparoscopic or open, laparoscopic is good if the field is virgin and the surgeon is aware how to do. But if recurrence takes place, or if the patient has been operated beforehand so that the gut is adhered, then best thing is to open it up so that you can dissect everything freely. Recurrence will take place only when the muscle becomes thick, muscle becomes weak because fat, accumulation of fat, or there is chronic rise of pressure, जैसे उसको constipation is there, or cough is there, or problem with the micturition, then only, or if you have selected a wrong suture, or you have not respected your tissues, you have left a hematoma behind, and then improper knowledge of anatomy. Otherwise, recurrence should not take place. So this much is enough as far as the hernia is concerned. But hernia, once you get, when you should operate? I always say that it is just like a passenger who travels daily from railway station to his home without ticket. He may not be caught for 20 years. He may be caught just after 20 minutes. So when you see a hernia, advise him to get, or her to get operated as soon as possible, because emergency is emergency. Chances of failure, chances of recurrence becomes much more if it is done in an emergency way. If it is done in a normal way, it's okay. Okay? Thank you.